Good morning, everyone. I hope and pray you're all safe. I am Dr. Vitug, a gastroenterologist. My task is to discuss with you pancreatic diseases. We will concentrate on three common conditions: acute pancreatitis, chronic pancreatitis, and pancreatic cancer. The pancreas has both exocrine and endocrine function. Majority is made up of exocrine tissue, responsible for the production of digestive enzymes. The endocrine glands produce insulin and glucagon that regulate glucose. The pancreas secretes a bicarbonate-rich fluid to maintain an alkaline pH, where digestive enzymes act more efficiently. Pancreatic secretion is influenced by secretin, which stimulates water and electrolyte secretion, and it's also gastric acid is the primary stimulus for the secretion of secretin. Other hormones that influence pancreatic secretion are your cholecystokinin, acetylcholine from vagus nerve, and your vasoactive intestinal peptide. The bicarbonate secreted comes mainly from the plasma. Autodigestion, digestive enzymes secreted by the pancreas are the following. You have your amylase for starch and carbohydrate digestion. You have your lipase, phospholipase, and cholesterol esterase for fat digestion. Trypsin, chymotrypsin, exopeptidases are for protein. These enzymes are secreted in inactive form. Autodigestion is prevented by the following mechanisms. First, proteolytic enzymes are packaged in precursor form called zymogens. Second, intracellular calcium homeostasis is achieved. Third, acid-base balance. Fourth, you have protective protease inhibitors. Fifth, chymotrypsin, which can inactivate trypsin, is present. Our first condition that we will be discussing is acute pancreatitis. Acute pancreatitis is an inflammation of the pancreas as a result of autodigestion. Early detection is essential to have good outcomes. It is divided into an early phase and a late phase. Abdominal pain is the foremost symptom of acute pancreatitis. It is sudden in onset, may be severe, accompanied at times by nausea and vomiting. Anorexia itself serves as a sign not to start feeding the patient. It may also be accompanied by diarrhea. On physical examinations, patients may have fever and jaundice. Hypotension, dyspnea, and tachypnea are danger signs of severe acute pancreatitis. Muscle spasm may also occur due to hypocalcemia. This is a picture of to show you Cullen's sign and Gray Turner sign. Cullen's sign is a bluish discoloration around the umbilicus due to hemoperitoneum, while your Gray Turner sign is a reddish brown discoloration around the flanks due to retroperitoneal blood. Acute pancreatitis is commonly due to gallstones and alcohol intake. Smaller stones increase the risk of pancreatitis. Alcohol, on the other hand, may cause premature activation and release of your enzymes. Alcohol may also cause protein plugs that block the pancreatic ducts. Acute pancreatitis may also happen after performing an ERCP. This is the reason why we utilize endoscopic ultrasound in some cases before doing an ERCP to avoid unnecessary utilization of ERCP and the possible complication of acute pancreatitis. Trauma may also cause pancreatitis as well as certain drugs. Listed here are drugs with a definitive association with acute pancreatitis, examples of which are your azathioprine, sulfonamides, tetracycline, furosemide, etc. Elevated triglyceride levels, which is seen in type 1 and type 5 hyperlipidemia, may also cause acute pancreatitis. Infections such as viral and bacterial causes are also possible etiologies. An Ascaris worm may migrate to the common bile duct and block the ampulla, resulting in acute pancreatitis. Hypercalcemia, hereditary pancreatitis, tumors, toxins, and surgical procedures, and autoimmune pancreatitis are also possible causes of your acute pancreatitis. The exact mechanism of acute pancreatitis is still not clear, but extracellular and intracellular factors seem to be involved. The three phases of acute pancreatitis are your first, the intrapancreatic enzyme activation and acinar cell injury. Second, the activation, chemoattraction, and sequestration of leukocytes and macrophages. The third, the effects of proteolytic enzymes on cytokines on other organs. These are the differential diagnoses for acute pancreatitis. You can see that they are a lot. Thus, a high level of suspicion and thorough physical examination and a good history is essential in the diagnosis of acute pancreatitis. The Atlanta classification states that 2 out of 3 of the following will support the diagnosis of acute pancreatitis. Number 1, if you have an acute onset epigastric pain radiating to the back. Number 2, if there is a threefold or greater elevation of your lipase and or your amylase level. And number 3, you have the classical imaging findings in acute pancreatitis. The Atlanta classification also divides acute pancreatitis into three, whether it's mild, moderate, or severe acute pancreatitis. Mild is if there is no organ failure and no local, regional, and systemic complications. In mild, the mortality is rare. In moderately severe types of acute pancreatitis, we find transient organ failure with local, regional, and systemic complications. Morbidity and mortality is higher as compared to milder forms of pancreatitis. And then the third is the severe acute pancreatitis, wherein you have persistent organ failure and is seen with local, regional, and systemic complications. In the early phase, it is associated with a mortality of as high as 36 to 50%. The laboratory data usually reveals the following: the amylase, if elevated 3 times above the normal, is actually diagnostic. Lipase is more specific to the pancreas and has a longer half-life of up to 12 days. Leukocytosis may also be expected. Hemoconcentration may serve as a warning of a severe disease if it is greater than 44 to 47%. We also watch out for the presence of prerenal azotemia. Creatinine levels may be elevated. Hyperglycemia may be seen due to the destruction of insulin producing cells. Hypocalcemia, if there is a saponification of your uh, of your calcium in the retroperitoneum. Transient increases in bilirubin, transaminase, and alkaline phosphatase may also be seen. Hypertriglyceridemia may be a possible cause of the acute pancreatitis. And of course, you check your blood gases to check for the presence of hypoxemia and the development or possible development of ARDS. CT scan is not usually requested for mild cases, but is an essential tool in predicting severity and presence of complications in acute pancreatitis. Findings could either be an acute interstitial pancreatitis or an acute necrotizing pancreatitis. CT scan is usually done after 72 hours unless the diagnosis is not clear. The Balthasar scoring for acute pancreatitis are graded from A to E, with A and B having good prognosis, while those with a Balthasar score of C to E have an increasing chance of mortality. This is a CT scan picture sample showing the difference and progression of findings from day 1 as compared to day 3, with patients on day 3 developing pancreatic necrosis. Other studies utilized are the following. One is your abdominal X-ray, which has limited role but may predict ileus and may reveal calcifications. Abdominal ultrasound is the most useful initial test, especially for detecting gallbladder stones. Endoscopic ultrasound may give a more detailed image of the pancreas and the common bile duct. MRCP, or magnetic resonance cholangiopancreatography, is non-invasive is a non-invasive way of assessing the biliary and pancreatic ducts. ERCP, or your endoscopic retrograde cholangiopancreatography, more likely is to be used for a therapeutic purpose in cases of gallstone pancreatitis. Acute pancreatitis is also divided into an early phase, which lasts for 1 to 2 weeks. This period marks the need to watch out for the development of sears and organ failure. The late phase of acute pancreatitis is characterized by a protracted illness. Patients affected more than 2 weeks may have complications of the kidney, develop ARDS, and are usually malnourished. We need to watch out for the development of necrotizing pancreatitis in these patients. The overall mortality of acute pancreatitis is 10 to 15%. Acute pancreatitis due to biliary pancreatitis is associated with a greater mortality. Age of more than 60, obesity, the presence of NAFLD, and comorbid disease like diabetes are also associated with a more severe attack of acute pancreatitis. Predicting severity is of the utmost importance to improve outcomes in the management of acute pancreatitis. Several scoring systems have been proposed to predict severity, presence of systemic inflammatory response syndrome or SIRS, Apache scoring, hematocrit level, the BUN, the BICEP score, the presence of organ failure and complications are markers utilized to predict a more severe condition. BICEP score looks at your BUN, mental status, the presence of SIRS, the age of the patient, and pleural effusion in the first 24 hours. A score more than 3 is associated with an increased risk of mortality. The Ranson criteria is used to assess the risk at the first 24 hours and at the first 48 hours. The higher the score, the higher the risk of mortality. A drawback of this system is the use of 11 criteria and a validity of only 48 hours. In the management of acute pancreatitis, fluid resuscitation is important, and lactated ringers may be better than saline. We initially put the patient on MPO or nothing per orem, but start feeding early as soon as the abdominal pain and the anorexia are resolved. Sometimes a nasojejunal tube or an NGT is required to give feeding to the patient. Pain relief is also important. Antibiotics are not routinely given as prophylaxis. In case it is necessary, it is important to use empiric regimen that will be effective against the pathogens seen in acute pancreatitis. Oxygen supplementation may be necessary if the patient develops hypoxemia. ERCP, as stated earlier, may be necessary to relieve ongoing obstruction and worsening condition in cases of gallstone pancreatitis. Patient with gallstone-induced pancreatitis ideally should undergo a cholecystectomy prior to its discharge. Nutrition is also important. Feeding early is important. We should avoid giving patients fatty foods and dairies. We resort to enteral feeding as soon as we can, which maintains a better gut barrier and limits bacterial translocation, and it's also least expensive. These following complications may develop in patients who have acute pancreatitis. Pancreatic necrosis may need to be treated surgically and requires broad spectrum antibiotics. Pancreatic pseudocysts are not uncommon, and pancreatic abscess development marks a more serious condition for patients with acute pancreatitis. Recurrent pancreatitis may occur in some patients, and alcohol and gallstones are still the most common reasons for development of recurrent pancreatitis. When the cause is not obvious, malignancy like pancreatic and ampullary tumors should also be considered and investigated as possible causes. CT scan is the most appropriate Now we go to chronic pancreatitis. It's different from acute pancreatitis because the damage to the pancreatic tissue is permanent due to fibrosis. The most common complaint is chronic abdominal pain with possible weight loss, steatorrhea, and diabetes mellitus. The following are factors or conditions associated with the development of chronic pancreatitis. Alcohol is the most common cause. Smoking is also associated with chronic pancreatitis. Cystic fibrosis, hereditary pancreatitis, autoimmune pancreatitis, and autoimmune disorders, congenital abnormalities, and radiation exposure, and idiopathic chronic pancreatitis are other possible causes. This is the TIGAR-O classification, which classifies the causes of chronic pancreatitis as follows: whether it's toxic or metabolic, whether it's idiopathic, genetic, autoimmune, recurrent, or if it's obstructive in nature. So this is a very nice mnemonic. In chronic pancreatitis, the amylase and lipase may not be significantly elevated as compared to acute pancreatitis. Bilirubin and alkaline phosphatase elevation may indicate bile stasis. Blood sugar levels may be elevated. Maldigestion may be detected by fecal chymotrypsin and human pancreatic elastase. CT scan is the most appropriate initial imaging modality which may reveal findings indicative of chronic pancreatitis, like calcifications, a dilated pancreatic duct, and the presence of atrophy. MRI with MRCP may be utilized if no specific findings are seen on CT scan. Endoscopic ultrasound or EUS is used to detect parenchymal and ductal changes, especially the presence of pancreatic duct stones. The complications of chronic pancreatitis are development of your abdominal pain, diabetes mellitus, malabsorption, metabolic bone disease, and pancreatic cancer. Biliary obstruction and pseudocysts are also complications seen in patients with chronic pancreatitis. Treatment of chronic pancreatitis is usually supportive. Digestives, digestives or digestive enzymes are given for the steatorrhea. Narcotics and analgesics for the abdominal pain. Endoscopic treatment by pancreatic duct stenting or EUS-guided celiac plexus block may be given for patients with chronic pain. Surgical intervention like pancreatectomy may be performed but may impair quality of life of the patient. Behavior modification is also essential or may be useful for those patients who have a problem with alcohol or for those who are alcoholics. Now we go to our last topic, which will be pancreatic cancer. Pancreatic cancer is among the top 10 causes of malignancy and a leading cause of cancer deaths. 80 to 90% are adenocarcinoma. It can occur at any age, but increased incidence is seen in people who are more than 60 years of age. Smokers are at an increased risk as well as those who consume fatty food and red meat. Most pancreatic cancers are seen in the pancreatic head and neck. Pancreatic tumors may be classified as either exocrine, the majority of which are adenocarcinoma, or endocrine, exemplified by neuroendocrine or islet cell tumors. Pancreatic cancer and tumors may also be classified based on origin. Tumors may originate from the ducts, from a pancreatic cyst, acinar cells, islet cells, or metastatic tumors from other organs. It is important to note that most endocrine tumors are benign in nature. Smoking is the most recognized risk factor for pancreatic cancer. Other factors associated with pancreatic malignancy are your obesity, a high alcohol consumption, a history of pancreatitis. Of course, genetics always plays a role in the development of malignancies, and possibly the diet, as we mentioned, a diet rich in red meat. Diabetes mellitus also carries a twofold increased risk of developing in the development of pancreatic cancer. Abdominal pain in pancreatic cancer is vague and nonspecific. It is usually mild epigastric pain radiating to the back. Weight loss is common and worsened by malabsorption and anorexia. Painless jaundice could be seen in pancreatic head cancer. Related to this, we must be aware of Courvoisier's law, which is a palpable gallbladder in the presence of jaundice. Pancreatic cancer is very difficult to diagnose, especially in its early stages. CBC might show a low hemoglobin and the presence of thrombocytosis. Amylase and lipase elevations may be seen, and half of those with resectable tumors may have elevated amylase and lipase levels. The bilirubin, alkaline phosphatase, and GGT may also be elevated, as well as your AST and your ALT. Tumor markers such as CA19-9 is elevated in 75 to 85% of cases. CEA antigen may also be elevated in around 40 to 45% of cases. Your alpha fetoprotein is of limited value in patients with pancreatic cancer. CT scan is still the initial diagnostic test done in suspected pancreatic cancer. This may still miss small tumors though. Malignant tumors appear as low-density lesions and is associated with pancreatic duct obstruction. CT scan may also be utilized for fine needle biopsy of a pancreatic mass. Ultrasound may be used as an initial screening test, but it's generally less accurate and may miss lesions less than 3 centimeters. Endoscopic ultrasound may be more effective than CT scan in detecting lesions less than 3 centimeters. Its detection rate may be as high as 99 to 100% in the hands of a capable endoscopic ultrasound operator. EUS is also utilized in doing fine needle biopsy of the pancreas, and it is superior to CT scan in assessing the T stage of the pancreatic tumor. ERCP again can be used to detect pancreatic and or biliary lesions. About 90 to 95% of pancreatic adenocarcinoma have abnormalities seen on ERCP. Obstruction of the common bile duct may be palliated by stent placement. MRI, MRCP may be better at detecting smaller lesions. It also serves as a non-invasive alternative in assessing the biliary tree and the pancreatic ducts. So in managing patients with pancreatic cancer, we still make use of the TNM system in staging pancreatic tumors. Surgery is the primary mode of treatment for resectable cases. Chemotherapy and or radiation therapy are used for adjuvant and neoadjuvant management. These two treatments, chemo and radiotherapy, may also be given for unresectable cases. Sometimes, palliation is the only alternative to control the pain and alleviate the jaundice and ensure patient nutrition. With that, our lecture is finished. Thank you very much for listening and have a good day. God bless.